And we are now live.
Hi, good afternoon, and welcome to this meeting of the Primary Care Access Delivery and Payment Task Force. This is a meeting of the Data and Research Work Group that it feeds into the work of the main Primary Care Task Force. I'm David Seltz. I'm the Executive Director of the Health Policy Commission, honored to co-chair the task force and also co-chair this particular work group with my colleague, Dr. Ryan Schwartz from Mass Health. Hi, Ryan. Great to see you. Thank you all to all of the members of this work group for being here this afternoon and joining this virtual meeting. As well, thank you to everyone who is following along online and following the important work of this particular task force. We have made a lot of tremendous progress so far this calendar year. I think this will be the final meeting of this particular work group for this calendar year. And we have a couple of agenda items that we're hoping to engage with you on today. But before we dive into the agenda for our virtual meeting today, we do have an order of business, which is to approve the minutes from our last Primary Care Task Force Data and Research Workgroup meeting, which was held on July 10th. And because this is a virtual meeting, I do have to do a roll call, and so we'll call on each of you with a call of the yeas and the nays to approve the meeting. But before I do that, I'm happy to open it up to see if there are any comments, edits, questions on the minutes themselves.
Nope.
Taking silence as no comments, edits, or questions, I'll be happy to entertain a motion
I'll move.
and a second.
Second.
Great. Thank you so much. And so we'll just go right in order as the slide here on the slide. So Ryan,
Yay.
Senator Friedman,
Yes.
Commissioner Caljo,
Yes.
Executive Director Lauren Peters,
Yay.
Suzanne Curry.
Yay.
Thank you. Dr. Friedberg,
Yes.
Dr. Mellon.
Yay.
Thank you. Laura Pellegrini
Yes.
and Barbara Rapson.
Yes.
Great, thank you. And we are also joined today by another member of the full task force, Dr. Wayne Altman, who is here today at this meeting. So for our agenda today, we really have two agenda items that we're hoping to get your input and feedback on. The first is going to be on, I'm going to turn it over to my colleagues from the Center for Health Information Analysis to talk about their primary care dashboard and specifically talking about their spring 2026 dashboard. They're going to share some of the updates that they're planning to make to that dashboard, but also want to invite some of your input about what are some priority areas of data that we could include in that dashboard. And so given the expertise of this particular work group and given the timing, this felt like just a perfect opportunity to be able to get your feedback and input into that important, kind of public-facing dashboard that the team at CHIA has worked so hard on. For the second half of the meeting, we're going to focus on another one of the deliverables that we had kind of pre-assigned to this particular work group, which is, and one that we haven't talked about yet. And it's deliverable number 5, which is to assess the impact of health plan design on health equity and patient access to primary care services. So we'll talk a little bit more about that when we get to that agenda item. But first, let's start with the CHIA agenda item. But before I turn it over to Executive Director Peters, I did want to recognize one of the task force members here who recently announced that she is going to be stepping down from her leadership at MHQP after 27 years of leading this organization. Barbara Rapson, you made the announcement, I think, in the last few weeks. And I just want to commend your leadership in that organization and the work that you have done over your entire career to improve quality, improve the transparency of our healthcare system, and leading such just a highly respected agency and being a partner and a friend over all of these many years. You're not leaving yet. And I think we're going to have you through, I hope, the remainder of the work of this task force. But I didn't want to let that go unmentioned, that news came out. So thank you, Barbara, for everything that you've done.
Thank you very much. It's been an absolute honor and really appreciate working with you all. And I will not be going away because there's lots of work left to do.
Yeah, absolutely. And kind of a perfect tee up because you and the organization have done some work on helping with this dashboard as well. So
Thank you.
with that, Warren, I'll turn it over to you and your team to help facilitate the first part of this conversation.
Okay, great, thank you, and good afternoon, everyone. Would echo sort of gratitude towards Barbara's leadership. As Director South mentioned, CHIA, in partnership with MHQP, has developed a primary care dashboard, and the goal really is to monitor in a standardized way year after year the health, if you will, of the primary care sector. So as Director South sort of teed up, we're looking to this group to provide input on any additional new metrics that we feel like are important and complementary of some of the discussions and work to date that the task force has taken under. So just as from a timing standpoint, before I turn it over to my colleague, we have typically published the dashboard every spring. So right now it is timely to be having this discussion as we're identifying areas for modification, new metrics that we want to include. So we welcome your feedback on any changes or potentially new metrics that we should be considering. Now, with that said, we may not be able to include them in this next iteration, but we're hoping to put everything on the table and hear from you what is most important and indicative of the health and performance of the primary care sector. So with that, I will turn it over to my colleague, Erin Bonney, who will provide an overview of the dashboard as it exists presently, and then go through some of the proposed changes, and then we'll open up for discussion to hear from you all. So with that, I'll turn it over to you, Erin.
Great. Thanks, Lauren. Good afternoon, everyone. So as Lauren mentioned, I'm here to give a brief overview of our primary care dashboard, some of the measures that we anticipate adding this year, and solicit feedback and brainstorming with you all on measures, specific measures or areas of the primary care system that we should investigate for inclusion in measuring the dashboard going forward. So if we can go to the next slide. So as a little bit of background or as a refresher before we dive into the specifics, the goal of this dashboard is to present timely and trendable summary level data about primary care in Massachusetts. And measures are grouped into domains. So there's 5 main domains, which we can see here on the slide. And then we also include some context information. And we have published 3 iterations so far, with the next publication is planned for June of 2026. So if we can go to the next slide, one after that, thank you. Nice little transition. So we are not going to talk about, I'm not going to go through each one, each of the domains or every planned update here, but want to provide and highlight some examples. So there's plenty of time for discussion by this group. So this first domain that we have is the care domain. So these are metrics that are focused on utilization and the quality of primary care. Generally uses a lot of patient-reported experience data as well as quality measures from the HEDIS data set. We are anticipating and planning on adding 4 new measures this upcoming year, reflecting the role of behavioral health services in primary care, as well as some additional measures on prenatal and postpartum care. Moving to the next slide. So access, those measures focus on access to primary care, utilization at the system level. On this slide and on the previous one, these are screenshots of the measures that are currently available in the dashboard. I realize they're very small, but to give an example, and that is all on our website as well. So in the access domain for this year, Two new measures that we plan on including are we're working on a measure that stratifies the number of primary care physicians by geography. We're considering zip code, we're also considering region within the state, and within as the second measure, so within a measure that we currently have of the number of Massachusetts residents that have reported difficulty in obtaining necessary health care. One of the reasons that they report is that they were told that the provider is not accepting new patients. So we're going to focus in on that particular reason and look at the percentage of residents that were told that the provider is not accepting new patients as a way to get at that aspect of access to primary care services. Next slide, please. Great. So the capacity domain, this is where we have a focus on the workforce and the pipeline of primary care providers coming into the system, as well as primary care providers that are leaving primary care. So over the past 2 or so years, CHIA has launched additional survey work to gain insight into the workforce of a number of sectors in Massachusetts, including primary care specifically. And so this year we anticipate being able to include some of the new data from that survey work in this year's dashboard. So to give some examples of data points that have been collected for other sectors include, statistics and insight around the race and ethnicity of the workforce of providers, vacancy and turnover rates, and impacts to access. So what steps a particular type of provider has taken in response to staffing vacancies or things like that, if there's an increase in people waiting for services. So broadly, we expect that we will be able to use some of this workforce data in this year's dashboard. And then can we go to the next slide? Thank you. I know that I'm moving quickly, happy to take questions after, but want to make sure and trying to keep this overview brief and concise. So as many in this group are aware, CHIA has been measuring spending on primary care services for the past couple of years. And so that data collection is what informs the finance domain that we have here. So in terms of anticipated changes or updates to the finance domain this year, we are looking at including more detailed data on services. So previously we've included what is the total spending on primary care? What is that percentage of total medical spending at the state level? As we have reviewed in previous meetings, we have additional data one level down in terms of the particular service categories. So how much was spent? What does spending look like for immunizations and injections? What does it look like for office visits, preventive visits, things like that? And so adding the spending amounts and data around spending for those particular types of services is something that we're considering adding to either the PDF dashboard or an interactive Tableau workbook that we also publish as part of our broader report materials. We publish this PDF that we're seeing snippets of here. We also publish an interactive Tableau that has additional detail, additional cuts that might be too detailed for the PDF or frankly just might not fit, in addition to a Excel data book, which CHIA publishes with all of our reports. And then if we could go to the next and last slide. So as Lauren said, we anticipate publishing the next iteration of the dashboard in June of 2026. And so thinking about this year or future iterations beyond that, we wanted to pose a few questions to this group. So what gaps exist? What areas of measures should be prioritized for us to investigate for future inclusion? On this slide here, we've included some examples of a few topics that we've heard from stakeholders that would be useful to look at to try to capture in the dashboard as either measures or if there are areas or domains of measures that would be helpful. But looking to this group in terms of if there are things either on this list that should be prioritized, what gaps still exist in measurement, are there specific measures that we should add? So I will pause here if there are any questions. I see Barbara has her hand up.
Yeah.
Yeah.
Oh, go ahead, Senator.
No, you got the hand up thing first, so you go first.
Sorry, I didn't see you, Senator. My screen was tiny.
That's okay. Go ahead, Barbara.
Okay, thanks. So thank you, Aaron and Lauren and David, for this opportunity to, for us to bring to you what we've done to date and where you might want us to go. Because uh, in the legislation, it did say that the measures, the task force will be the reporting mechanism for the task force, and the task force can come up with, measures in our work that we feel are important. So one of the things that I will mention is sort of the last one, which are really market measures. And one thing we originally thought maybe we'd include a market domain, but we didn't at the time. But as we see more clinicians, primary care clinicians moving to concierge medicine or direct care, as patients are moving to urgent care and we have no sense of what kind of utilization, trends there are in Massachusetts. And another one that I think is really important that I've brought up before is the idea of practice ownership, that how many practices are owned by whom, and that there's an increasing number with Acton Medical just recently getting bought out by Optum. There are a lot of our big groups that are owned by Optum. And the ability to trend that at the practice level feels like something that would be really important for the task force work. So thank you.
Thanks. I'm gonna try to go in order. So I think Senator Friedman.
Yeah, I think those are all good points, Barbara. I have two questions. You said that you were going to start tracking primary care by region, by geography. Did
Yeah,
I hear that
so
right? So
so we
how
are
do you have all the information that you need in order to be able to do that? I mean, I know you've got different places where that information comes in, but can you gather all of do you have a place to get all of that information, like small independent practices um, or will you be able, do you need more assistance in order to do that?
So the specific measure that we're looking at including would be sourced from our APCD. So we'll capture everything that goes through an insurance claim. So particularly to primary care, the caveat there is if there was a direct care clinician or potentially concierge medicine that does not bill to insurance, those would not be picked up. But the particular measure that we're looking at would use APCD and look at the number of physicians in Massachusetts that are primary care clinicians and be able to tie them to either a zip code would be the most granular, or we're looking at potentially being able to roll that up into a region so that you could look at the availability or the number of primary care physicians in Western Mass versus Southeastern Metro Boston at that regional level, which we recognize is sometimes more helpful to get a summary level. But for others, the zip code might be helpful as well.
Okay. And then all the new metrics that you're adding, are they all coming from the APCD? Or are we
Uh,
asking for more
So the
information?
measures that we are potentially adding are coming from a variety of sources. The dashboard itself sources measures from all over, leveraging CHIA data where we can, MHQP data. They bring a lot of the patient experience survey data as well. So the new measures will be based on, for example, some of the stuff from the Massachusetts Health Insurance Survey that CHIA puts out. Our CHIA workforce survey data will inform some of these. APCD, MHQP's patient experience survey, and some HEDIS quality measures as well. So a variety of sources.
Okay, but it doesn't sound like we're now adding more reporting data to the primary care practice or I guess the system.
Correct. Our goal has been not to increase reporting burden.
Okay, thanks.
I'm sorry, I didn't see who went first, but I think Mark might be next, and then Laura.
I think it was Lori next, or Lori, sorry, Laura, go ahead.
Thanks.
Well-
So with that, follow up on Senator Friedman, are you able by geography to see if the PCP is independent or part of a system?
That is a good question. I don't know that off the top of my head. It might take an additional set of linking, but if that is something that would be of value, we can add that to the list of things to look to investigate to see if we can do that.
I think we would. And then also,
Okay.
if the practice has behavioral health integration, if they've been able to integrate that into their practice, would be very
Can I ask
helpful
if
for us to know.
Can I ask a follow-up on the behavioral health integration? Are you referencing, do you mean behavioral health integration as in they have a behavioral health clinician on staff? Is
Yeah.
it the makeup of the, okay.
Yes.
Dr. Freeberg?
Thank you. Yeah, I just have a few thoughts on new measures. Some are just stratified versions of existing measures. So for the primary care spending, both absolute and especially percentages of total medical expense, I would strongly suggest granular stratifications by age, even within the pediatric population, as well as stratifying by comorbidities. That just renders different, regions, payers, provider systems more fair to compare to each other. Also, for Medicaid, I recently learned that provider taxes are not included in the total medical expense denominator or the primary care spending numerator. That's something to potentially address in the underlying data. I don't know what direction that will deflect the percent primary care spending for mass health. But it probably will be a meaningful change, and certainly will be a meaningful change for the TME figure, given the size of provider taxes in Massachusetts. Final suggestion is, I think Massachusetts is a little unusual in excluding behavioral health services from the primary care spending figures, both in terms of absolute spend and the numerator for the ratio. I would at least encourage making a version of that where the behavioral health codes that occur in the primary care spending are included as primary care spending. Thank you.
Thanks for that feedback. As a note, we do include we look at behavioral health services that are delivered in a primary care setting. We do have that separated out in our spending report, and in our report that focuses exclusively on primary care and behavioral health spending, we do look at that as a proportion of both behavioral health and of the primary care spend. But thank you for the feedback.
Commissioner?
Thank you. I want to echo the interest in correlating the spending accumulated by health system or hospital within the data that we're seeing. And I guess I have a question, and I ask it with all humility in the sense that I really don't know how we do this or if it's something that's even possible. But we're capturing the amount of spending that's flowing out of the health insurers through utilization claims data. But we're not correlating any ancillary spending or the lack thereof from the health system back down to the practice group. And I wonder if there's a way to capture that or require additional reporting from health systems in order to capture that data and net out the claims-based spending with other items that may be deficient or sufficient for primary care practices, depending on how they exist within a larger healthcare system. And that's a big question, and I don't know what the answer is, but was wondering if anyone could speak to that.
Erin, do you want to speak to sort of how we use system level patient spending as a proxy for the providers spending on primary care?
Yeah. So our primary care spending data, we collect it from the insurers and they report it to us based on along the dimension of provider groups. So we do capture, to your point, that payer to provider amount of spending at the system level. In terms of how primary care is being distributed within the system, that is not something that we currently capture or are able to capture in our aggregate data collection. We have heard throughout standing up this collection and this reporting process over the past couple years, that spending within the system would be helpful. But what we have right now is really, you know, we have the patient size panel, so we can look at a spending for a system on a per member per month basis. But we don't have anything more detailed than that, unfortunately. In the interest, because I think it would require reporting by the providers themselves. And we've been cognizant of both of reporting burden over the past few years.
I'd be very interested in capturing that information over time, particularly if it's done within a structured setting. Because I think we're getting a directional set of information that's helpful, but it's not telling the system set of questions that I think also we have heard, all of us have heard stories about, but frankly, we haven't been able to arrive at. So I know it will merit a lot of care and attention, but I feel like landing that would be really helpful. Thank you.
Yeah, Commissioner, I fully agree. And I think that is, to me, one of the deliverables that this task force needs to land on. That's deliverable, in my mind, deliverable number 2 is tracking the money. And so, we've had some conversations about that. Even HPC and CHIA, we've had some conversations about that. So that's something where, I think we're still kind of wrestling with that, but we're going to have to kind of come up with some ideas of and a structure about how to move forward on that. That has to be part of our recommendations and deliverables for the task force. Suzanne?
Thanks, David, and thanks to your team. I'm going to echo a lot of what has been said already. I want to start actually with a question. So there was the conversation about trying to track capacity for primary care physicians by geography. Since you already look at physician assistants and NPs, would that also be included in what you're looking at as far as capacity?
So
Or
we
is it
do
just the
already,
physician level?
so we do already include measures on the number of PAs and the number of NPs in the dashboard. In terms of the new measure that we're looking to stratify by geography, for this year, it would be only physicians.
Okay. All right, that's helpful. But thinking of maybe looking at PAs and NPs in the future.
So we recognize the important role that PAs and NPs play in the healthcare system. Doing the physicians only it's a data limitation. It's a data set quirk on our side.
Okay, great, thank you. And I just wanted to echo some of the comments around information that we can get about, integrated behavioral health and other things Dr. Friedberg talked about, and just around stratification for pediatrics too, and including the spending target, but maybe some of the other pieces that you look at. I know that there is some stratification in some of the areas. I have to look at the specifics again, but would love to work with you on that about kind of some age-based stratification on some of the other areas. Don't want to overwhelm the dashboard also because it is pretty comprehensive. Then I know that we are going to be talking later about cost sharing. So just thinking about how we can incorporate that more into the primary care dashboard as well.
Okay, thank you. In terms of the age stratifications, your point is well taken and we agree. Some feedback that we've heard previously is one option is we could look at under 18, over 18 to break it down more further to Mark's point earlier. One option is we could look at adolescents, so say 12 or 13 to 17, or we could do a variable and breakdown, perhaps recognizing the differences in primary care needs, so like 0 to 5, 5 to 10, and then maybe 10 to like we could do something like that of every couple years. Does that sound appropriate? Does that sound the right level? Not too much, too little?
Yeah, that sounds great. And I think breaking it down, especially because we know, obviously, in the earlier years, there are more primary care visits just as well visits, right? And then thinking about what the right age ranges are from there. That would be great. Thank you.
I'm going to go to my co-chair, Ryan, and then come back to you, Dr. Mellon.
I just wanted to respond to the question around age stratification. I know
Yep.
Mark's team and our team have had a lot of discussions around this. I think it's actually worth cutting really clearly in the 0 to 5 range. The 0 to 1, 1 to 2, 2 to 3, like even within that range, you see a fair bit of stratification. Once you hit, and I'm not the expert here, but once you hit the school age, you see more of a stability until you get to kind of young adults. And then having the adult time frame is really important. And then there's some, whether it's over 65, under 65, over 60, under 60, we can talk about what the age cutoff there is, but there is definitely a inflection point at some point in the transition from adults to geriatrics, where you're going to see a significant difference between what happens in the specialty care side as well as what happens in the primary care side. And I think one of the points that Mark's team has emphasized to us in the past, which has been helpful, is in particular as we think about what is the quote unquote right amount of primary care investment. It's I think very simplistic to say there's a single percentage across the board, and we really probably need to be thinking much more granular around what does it look like for good primary care access in pediatrics 0 to 5. We've done our own data disaggregation internally, and when we look at our really young kiddos, our TCOC is like upwards of 20-25%, because let's be honest, most little kids don't use cardiologists or gastroenterologists, etc. Some of them do, but it's a much lower percentage. Whereas when you get into 65 and above, your actual primary care spend starts to decline because much of that care starts to be centered in specialty care. So I think, Aaron, there's a lot of value in further disaggregation of primary care spend relative to age, and to the extent that we have granularity in the data can actually be helpful for us to also think about what the right amount of investment is.
Thanks for that.
Thanks, Ryan. Dr. Mellon?
Yes, thank you. I'd like to echo all the points that Dr. Schwartz made, but in particular, that last one about Medicare. I've mentioned before in our meetings that I worry about the fact that Medicare data about care is less available or unavailable for this important work. And I know you're working on it, but I want to point out that there will be significant differences among individuals and even sites with regard to their data, depending on the age of the people they're taking care of, and at the very young age, as Dr. Schwartz said, and also at the what I'll call the medium to older age. There are, of course, all sorts of factors that influence all of the good measures that you're talking about adding. And I wanted to point out just a couple of them. For the vaccine work, we hope, I'll speak for myself, I hope that that we're continuing to vaccinate people at a great rate, better, right? And that's probably all of us at the meeting would agree with that. Depending when the data are measured for the year that for the report you're generating for June, I would be surprised if you don't see a decrease. And part of that decrease is kinds of things that are making headlines. And another important part of that decrease would likely be attributed to employers who chose not to require vaccination anymore, but to encourage it, or maybe just be silent as to it, and to a factor which Massachusetts did a great job of remedying, but did have a very important impact. We'll all remember a few weeks ago, COVID vaccine couldn't get itself into pharmacies, where so much of the administration occurs, because of wonderful Massachusetts regulations or laws that spoke to, I believe, approval by CDC, and we all know that story. And it took, I think, about a week, maybe a little bit longer. At the time, it felt to me like a year, as a primary care physician taking calls from my patients, but it wasn't. It was very rapid and great action by the Massachusetts leaders. That said, people who really felt they needed it were going to New Hampshire, going to other states, adjacent states that had it, or if they happened to be traveling, they were getting it there. Who knows what exact number that is? Those data don't come into the Massachusetts vaccine registry. But as a point, to make that point, there are all sorts of well-intentioned reasons that are not fully in the control or at all in the control of a PCP. Similarly, I've become concerned more and more these days about the measure of whether a practice is open or closed when we're judging that by what the patient has been told or anyone calling has been told. And that is because there's such a thing as a closed practice, there's such a thing as not accepting new patients, and there's such a thing as not participating in the particular health plan that the patient is a member of. That's been prominent in recent weeks. One of our outstanding health plans and one of our outstanding practice groups, very large practice groups, was working hard. And then after the announcement that the large practice group would not be available, it turns out they worked it out, which is amazingly great. And in fact, physicians will remain available in that large and wonderful health plan. Patients don't understand these nuances between not in my health plan, not available at all. And to make things even more difficult, if you go on the website and look up a doctor, you Google a doctor's name, look at health grades or any of the others, some of those, they all ask our open closed hours. And if you tell somebody your office closes at 7 p.m. and the patient looks at 8 p.m., it says in red, closed. That means it's closed at 8 p.m. It's going to open up at 8 o'clock in the morning. That can be, it took me a while to figure that out, frankly. And we can't control the numerous entities that are reporting information they feel is useful to their consumers. But I wonder what impact that has on patients who are looking for a doctor. Thank you.
Yes, agree that it is quite nuanced in terms of all of the, accepting new patients versus a closed panel. The measure that we intend to include, which is from our Massachusetts Health Insurance Survey of residents that reported that they had difficulty accessing primary care when they needed it, or accessing necessary healthcare when they needed it. What percentage of those were told that the reason they had difficulty accessing was because they were told that the practice was not accepting new patients is certainly a proxy measure for some of these broader access issues. In terms of, is there any data source or any measure, or is there anything specific that you would recommend that we look at instead to better get at the variation that you just mentioned?
I'd be glad to talk to you about that offline. I have some ideas about that probably take longer than we should spend in this meeting. But I will say that try though they might, memorizing the exact language that an office clerk said to you when you're on the phone, you're desperate for a doctor, is a taller order than I'd like to expect of our people in Massachusetts calling for help. And frankly, getting it exactly scripted, having our support staff know exactly what words to script for each person who's calling, probably not the best use of our healthcare dollars, right? So to your point, finding another way to measure it would be great. And not having people think that closed at 8 p.m. means the doctor's gone for good. So that's a whole different problem, but yes. So I'm happy to talk offline. How's that? Is that okay?
Sounds great. Thank you.
All right, Wayne, I'm going to give you the last voice on this, and then I'm going to move us on to our second topic.
Thank you, David. I'll be brief. I just wanted to acknowledge Barbara and MHQP and Lauren and Chia. This dashboard is amazing and has received appropriate national recognition for what it's done. I think the new proposed measures are fantastic. In particular, the percent of people who are we're told that providers are not accepting new patients is important data to collect. I like that one a lot. I like all of them. The one I would add for consideration is, and I'm kind of thinking about my colleague, Dr. Steve Martin, who's on this task force, the number of people who are calling up an office and saying, I'm sick and I need to be seen today, specifically that cohort that is being turned away. I don't know if that's possible to measure, but if it was, I think it would be quite useful. Thank you very much.
Thank you for that feedback. And yes, agree. Wait times and also wait times for specific instances, whether recognizing that there's the wait time for a well visit is potentially different than wait time for a sick visit, has been on our list, and we're working on it.
Yeah, Wayne, it doesn't get exactly to your point, and I think Aaron just appropriately addressed it. But I do know that one of the survey questions is around people who went to self-reported that went to the emergency department for a condition that they thought didn't need to be in the emergency department. And then there's a follow-on question, why? And one of the answers could be, I couldn't get into my primary care. And I think that's actually one of the number one reasons that people say. So another way of kind of thinking about people who were in that sickness position,
Category.
you know.
Right on.
Great conversation. Thank you so much. And I think a lot of food for thought for our Chia friends, but also really good information for us on the task force and for this work group. So I'm going to move us on to the second topic for today, which, as I previewed at the beginning, is another one of the deliverables for the task force. Next slide, please. And this deliverable is assessing the impact of health plan design on health equity and patient access to primary care services. The deadline and the statute for this one is March 15th. And so where we thought we would begin this conversation around health plan design and impacts on access and equity is to first start talking about cost sharing. And so it just so happens that this has been an area of interest to the Health Policy Commission, and just so happens that we have been putting our own research muscle, so to speak, behind trying to understand trends in cost sharing, and specifically some of the cost sharing in ambulatory and primary care settings. And so to tee off this conversation, I'd first like to share a little bit of the work that we've done here. This is kind of new work, work that we're going to be releasing as part of this year's cost trends report. And then we'll spend the remainder of the meeting talking about what are the implications for this for primary care specifically, what policy recommendations might we want to consider, what is the right design of cost sharing for primary care, and we'd be really interested in the work group's input and thoughts on all of this. So first, to just give us a little bit of that data foundation and understanding what we see out in the market today, I'm going to turn it over to Sasha Albert to give us that research. Thank you.
Thank you so much. Excuse me. Thank you so much, Director Seltz, and good afternoon, everyone. So today I'll be sharing, as Director Seltz mentioned, a selection of the analysis that will be published in our upcoming cost trends report, focusing on cost sharing in the Commonwealth and how it might be improved. And before I launch in, I'd just like to thank my colleagues Alicia Duran, Yua Huang, Amanda Ketchmar, Leiden Marcelat, and Sarah Sadownik, whose work I'll be discussing today. So our look at patient cost sharing is really motivated by concerns about affordability and access. Cost sharing can create particular financial challenges for patients because it often can't be anticipated, especially deductible-based designs that are becoming increasingly common in the commercial market. And we know that policymakers in the Commonwealth have sought to address high and growing out-of-pocket spending through both legislation and regulation, such as regulatory guidance via the Division of Insurance, limiting deductible and copay growth, and legislation passed last year capping out-of-pocket costs for certain prescription drugs. And we also know that any efforts to reduce or slow the growth of cost sharing, of course, need to be paired with efforts to address the underlying drivers of healthcare spending, because total cost sharing dollars are a zero-sum game with premiums. Patients are either paying to have health insurance or paying when they use care. Next slide, please. And we know that shifting costs to patients via cost sharing has long been a key feature of health insurance design. And when we say cost sharing here, we're talking particularly about copays, coinsurance, and deductibles. And in addition to offsetting premium increases, as I mentioned, cost sharing can also be used to further other goals, such as discouraging use of healthcare resources of limited value. The idea that patients will think twice about using care if they have financial skin in the game. Or steering patients towards higher value care by varying cost sharing across services and settings and providers. But crucially, and you'll hear me talk about predictability a lot today, to be able to achieve those goals, patients need to be able to estimate their cost sharing obligations in advance of using care if paying cost sharing is going to inform their decision making. Next slide, please. And we know from the research literature that typical cost-sharing design, and especially deductibles, has not actually led to more judicious use of healthcare resources. The research literature broadly agrees that cost-sharing reduces care use across the board, both avoidable and essential care. Research also indicates that the deductible is the most problematic form of cost-sharing, and that its use has grown in both prevalence and in dollar amount. In Massachusetts, the share of commercially insured residents enrolled in high deductible health plans has risen a lot. It's grown from 19% in 2014 to 45% in 2023. So with all that background, I'll now move to our analysis. And the first of our two sets of analyses looked at trends in cost sharing across care settings in Massachusetts with a focus on challenges associated with deductibles. This analysis uses the all-payer claims database, including residents under age 65 who had a full year of medical and pharmacy enrollment, coverage enrollment, and who had any care use. So to start with, we see that the amount of cost sharing that patients are paying is growing faster than the amount that insurers are paying for patients' care. Patient paid cost sharing amounts increased by 29% from 2019 to 2023. Compared to a 24% increase in insurer paid amounts. And if we break down this orange part of the bar into copay, coinsurance, and deductible, on the next slide, we also see that deductible spending is the fastest growing component of cost sharing and is actually driving the overall rise in cost sharing over time. We also broke down cost sharing per member per year by service category. And here you can see that these results reflect both the frequency of use of different kinds of services and the amount of cost sharing paid for that use. These are cost sharing amounts per member per year across all members, regardless of whether they use the specific service in question. So for example, while inpatient stays are costly services with high cost sharing on average, they occur fairly rarely. Not everyone is going to be hospitalized in a given year. Which results in low average per member per year cost sharing for inpatient services, under $50 on average. By contrast, evaluation and management visits are very common, even though they're less costly. But because they're so common, they are the source of the highest per member per year cost sharing at almost $260. We then broke down cost sharing specifically for ambulatory services by share of cost sharing for each service attributed to copay, coinsurance, and deductible on the next slide, to show how much variation there is across services, which reflects differences in benefit, design, and price. So there's a lot on this slide, but here we highlighted labs and tests on the left and E&M visits on the right to show that cost sharing for labs and tests is overwhelmingly paid towards patients' deductibles, which makes it pretty unpredictable, while cost sharing for E&M visits is paid by a mix of patient copays and deductible payments. And because benefit design drives how patients experience their cost sharing obligations, services like labs that have both high utilization frequency and high deductible use mean that many patients are going to receive unpredictable bills for these services. So to get into this a little more, we did a dive into cost sharing for typical E&M problem-based visits. So this is those visits where someone knows that they have something that needs attention from a clinician. A common benefit design is applying a copay for the office visit itself, and then applying a deductible for any ancillary services that patients receive while they're at the visit. So each of these three sections of the graph show the distribution of cost sharing for E&M problem-based visits, first without any ancillary services, and then visits that include imaging, and visits that include labs and tests. And you can see that without any ancillary services, 75% of visits had under $50 of cost sharing, none of which was paid towards patients' deductibles. In other words, 75% of visits, patients only paid copays. For visits with imaging in the middle, about 30% of visits just had copays. But for 25% of visits, patients paid $100 to $200, mostly towards their deductibles. And for visits with labs, I want to highlight that 6% of visits had deductible payments of $200 to $300, and an additional 3% had deductible payments of $300 or more. These are not large percentages, but these are substantial bills for labs that patients may not have gone into their appointment knowing they were going to get, and where patients would not have had the wherewithal to consider the value of the lab or the opportunity to try to find a more affordable place to get the lab. In other words, the skin in the game theory really breaks down when the care use is unanticipated and patients don't know what it's going to cost. On the next slide, we provide an illustrative example of just that kind of situation, where a patient goes in for a problem-based visit and then receives a large unanticipated bill. So on the left-hand side, we have the patient's clinical path. A patient has uncomfortable symptoms and schedules a visit with her doctor. She pays a $25 copay when she arrives at the office. And during the appointment, her doctor asks for a urine sample, performs a swab. Her test result come in the next day with a diagnosis of bacterial vaginosis. And the doctor sends a prescription to her pharmacy. The patient picks up her prescription, pays another copay, and with treatment, her symptoms improve. 30 days later, she gets a bill for $193 for the lab test because it was subject to her deductible. So for this episode of care, she's paying almost $230 in total. There's nowhere in this clinical path where she could have shopped around for her labs. And even if there was, it's unlikely that she would know what her lab was going to cost in order to inform that shopping. And as you can see from the bar graph on the right, this case study represents average cost sharing amounts for bacterial vaginosis diagnosis and treatment. And while 41% of patients are not paying anything for this scope of care, about 20% are paying $300 to $400 for towards their deductible for the same clinical scenario. And another almost 20% are paying even more than that. And the key thing is that it's unlikely that a patient will know in advance which of these bars they'd fall into. And knowing what we know about the high cost of living in Massachusetts, this is pretty sobering. A lot of families are not going to be able to afford an unexpected $300 bill for a routine lab. So moving to our next topic, our second set of analyses look at another area of cost sharing where predictability is a concern, which is cost sharing for preventive services. Next slide, please. So since 2010, as I'm sure we all know, the Affordable Care Act has required private commercial health plans to cover certain preventive services without patient cost sharing. Since it has been robustly demonstrated that cost sharing has been found to contribute to reduced use of health services when it's applied across the board, the ACA preventive care mandate aims to facilitate and encourage the use of high-value preventive care by exempting those services from cost sharing. Next slide, please. And although the preventive care mandate has been associated with increased use of preventive services and reduced patient cost sharing, research also finds that an estimated 40% of preventive visits in the US actually do continue to have cost sharing. So the goal of facilitating patients' use of these high-value services would likely be undermined by the continued application of cost sharing. So for the HPC's analysis of cost sharing for preventive care in Massachusetts, again, we use the all-payer claims database for commercially insured residents. And in the full cost trends report, we explore examples of 6 preventive services identified in the research literature as often having cost sharing. Today, I'll be sharing results for 2 of them, preventive visits and diabetes screenings. And I want to note that for most preventive services, any cost sharing we find could be thought of as an enforcement problem. These services shouldn't have cost sharing, but sometimes they still do, even if it's an error. But for preventive visit episodes, which is what we're calling, physicals, checkups, well visits, those are a little different because while the ACA requires your physical to be free, if any non-preventive services occur at the visit, it's allowable for those to have cost sharing. So for any cost sharing we find for well visits could be thought of as a policy execution problem, where the policy is working as intended, but patients may still have cost sharing and sort of, confusion and any sort of attendant challenges that come with that. So just wanted to share upfront that how you interpret these results varies a little bit by service. So getting started with preventive visits, multiple ACA recommending institutions recommend that patients receive an annual preventive visit with more frequent visits recommended for very young children. And again, during preventive visit episodes, if a patient receives services that are not covered preventive services, they can be charged cost sharing. So if a patient raises a health concern during their checkup, guidance allows their primary care provider to also bill for a separate problem-based visit for which cost sharing could apply. So for this analysis, we looked at cost sharing for all services that occurred during the preventive visit episode. Next slide, please. Sorry, one more. Thank you. So to start with, we find that about 30% of preventive visit episodes have cost sharing, and that when patients do pay cost sharing, they pay on average about $75 as of 2023, mostly due to deductibles. Rates of preventive visit episode cost sharing also vary by payer, from 18% of visits covered by Health New England to 44% of visits covered by United. And the amount patients pay when they have cost sharing also varies quite a lot, from an average of $50 for care covered by Health New England to over $100 for care covered by MGB Health Plan. And when patients do have cost sharing, that 30% of patients with cost sharing, the cost sharing is largely related to services other than the preventive visit itself. It's largely related to the ancillary services that occur as part of the same episode of care. So on the next slide, we see the prevalence of common items that are billed as part of a patient's preventive visit episode, with the light blue part of the bars showing the share of those services that have cost sharing. When patients are billed for a problem-based visit during their preventive episode, that problem-based visit will have cost sharing 87% of the time. But the most frequently occurring source of cost sharing during preventive episodes is labs and tests, which happen in nearly half of all preventive visit episodes and have cost sharing about a third of the time. And again, this is allowed under the ACA, but I would suggest that it might undermine the goal of having a fully covered annual checkup, because part of the goal of these checkups is for clinicians to have a complete picture of patients' health so they can address issues in a timely way. And if patients receive an unexpected bill when they raise health concerns, that can undermine their trust that their preventive care will actually be free, and kind of undermines the reason we want patients to be having these visits. They're financially on the hook for doing what they're supposed to be doing at their annual physicals. And as one might expect, this happens more frequently for patients with chronic conditions.
Sasha, we have a question from the commissioner.
Yes, thank you.
More of a comment. The data year that you're looking at was prior to the passage of the PACT Act, which included new protections for chronic care services from cost share. So I just want to note that will be alleviated or should be alleviated in the new data set as it comes forward. And then secondly, this is more observational. I do think this is difficult for both the doctors, the patients, and the health plans, in the sense that there's not really an episode of care that's occurring in the same way that maternity services are constructed. And so I just raise it in the context of problem solving as opposed to it being, black or white. I think these are difficult interpretive issues where our health plans are working within the construct of the current law and the current provisions correctly. This is more of a policy consideration about how do we want to consider this a bundled set of services, and how far does that extend? Does it extend out to include lab work or particular tests that stem from an initial office visit or not? And that's hard because the construct that was missing or that we did not include is that cost share and premium are directly related as well. And as you pull down the lever on one, you may raise the lever up on the other. And so that's also a consideration for us to evaluate. I don't really have a strong feeling on it, but I just want to raise that balance, that fulcrum.
Yeah.
And we're actively engaged in this topic. The DOI, as you noted, recently moderated cost share within the construct of the merge market rate to kind of a metric that grows in pace with inflation. So I'm sympathetic to the larger issue. I just want to note the important nuance on the extenuation of or the extension of the office visit. It's a harder set of questions that I think we all grapple with.
Yeah.
Thank you. I appreciate that. And to the point you raise about sort of the seesaw of premiums and cost sharing, we in a little bit later in these slides we've done some modeling that gets at that challenge.
Awesome. Thank you.
And Commissioner, I think you're absolutely right. We're trying to tee up, a conversation here that is challenging. I think one of the themes that has come through for me in this work is a value around predictability. And the fact is that for so many patients, they don't know until they get that bill. And the deductible is a big part of that unpredictability. If I have a copay and I know that my copay is going to cover my office visit, and that office visit may include a test, a lab, and imaging, but that copay is going to be covering all of those services that are part of that regular office visit, and I'm not going to get stuck with the bill later. Where you draw those lines around the circle, how where you price that in terms of a copay, all very important questions, but at least I know, and that's not something that's going to come back, later, 30 days later. And
Right.
health plans are experimenting on that concept.
Yeah. And it could be where the policy lever is more consumer disclosure, for example, in the construct as we debate this or talk about it more. I think that's the appropriate amount of nuance, but I just wanted to note it, so I appreciate that.
Yeah. Happy to kind of pause here and take some questions and comments on this. Dr. Friedberg?
Yeah, just a clarification. I'm a little confused on something. Seems like there's two sort of different concepts being intermingled here in a way that I'm having a hard time telling apart. One is, the ACA and other associated, similar laws that have to do with the elimination of cost sharing for preventive services don't cover everything that might be done at a primary care visit. I mean, that's I think kind of widely known. What I also heard, though, is, and maybe I'm mistaken about this, that perhaps the carriers are being accused of violating those laws and regulations. That would be a pretty important thing for us to get clear on. We have a large and robust regulatory department that is very much attuned to not making those kinds of violations, and we would want to know very quickly if that's actually what's being said.
No, I think on the preventive side, the point we're really trying to make is that the system is so fragmented that it's impossible for there to not be errors that result in cost sharing for patients when maybe there shouldn't be. That the federal guidance is updated on a rolling basis, and then carriers need to communicate that to providers. Each payer has its own rules for how to bill a particular service so that they will fully cover it. And so providers need to bill, in an updated way with the federal guidance correctly for each payer every single time. And that amount of fragmentation just creates numerous opportunities for confusion, being out of date, and error. And so this is more of a story about complexity than sort of violating the rules.
Yeah, I guess I struggle with the descriptive error. And the reason is that, we monitor the market. Our agency provides advice and counsel to the carriers around compliance with the requirements under federal and state law. And we acknowledge consumer complaints and root them out. If there was a systemic set of errors, quote unquote, I think that we would be motivated to take greater system action. What we may have is the application of particular services working in a confusing way, but not incorrectly. And I think that's different. But anyway, I know others have observations, so I'll just step aside.
Yeah, I think that's a fair representation, Commissioner. And I want to be clear that we're not accusing any violations of law here. We are reflecting, I think, Mark, as you said, that there is a known fact that the ACA preventative law doesn't cover all of these things, and we are showing that. And where does that happen? How does that happen? And how does that impact patients? And really just trying to show that, and that there's some variation there. Barbara?
Thank you. So I just wanted to mention that these high deductible plans encourage the worst behavior in patients. And I'm going to give you two examples. One is my son, who went to the doctor, and before he went, I said, "Okay, Lewis, make a list of everything you want to talk to the doctor about, because that's what smart paper patients, ask questions." And he came back really grumpy, and he said, "Do you know what happened? I got charged for this, and I got charged for this, and I got charged for this, because these were things I came to the doctor for, and I was expecting a free visit, and now I have to pay this bill." So this is a 20-year-old, 20-something. Another example is an employee. MHQP had a high deductible plan, and finally I said, "No, we can't do this. We have to move away from this." And we went to an HMO, and one of my employees came to me and was so grateful, because they said, "Look, I kept my kids from going to visits when I wasn't sure what was going on, because I had no idea what I was going to be charged." I mean, just what you said, how unpredictable it is. And so we really have to think about this from the patient and what we're guiding the patient to do, and choices we're guiding them to make, which were really bad decisions. So finally, I would be remiss if I didn't loop back to Wayne's comment. Sorry about this, but when you mentioned, Wayne, about the measure you want is when a patient calls up and said, "I'm sick, I need an appointment." That's actually a measure on the MHQP statewide survey. So we do have that data for patients who do have a primary care clinician, but not for those that don't have a primary care clinician. So thank you.
No, thank you for raising those examples. I think that's one of the reasons that we focus on ACA preventive services, is that, in theory, this is as predictable as it gets. Like, patients on paper know that this service and that service are supposed to be fully covered, and then either the nuances of the service, or something about what the patient raises at their visit, or something about how the service is coded, mean that they end up actually getting a bill, and that creates a sense that the healthcare system is opaque and unpredictable, and that they can't actually trust that care will be covered when it's supposed to be, and could create a chilling effect on their willingness to seek appropriate care in the future.
Or ask questions about what they're concerned about.
Right.
So I'm going to just use my chair prerogative. I will get to everyone with their hands up. But Sasha, can I just move you to slide 42 and just to give it some examples of how some examples of how some states and health plans have tried to experiment on this problem.
Absolutely. Yeah. Thank you. Yeah. So we included these to show that, to give some examples of thinking creatively about cost sharing. One is from our very own Health Connector. The Health Connector has been piloting expanding eligibility requirements for the Connector Care program, which includes a plan design that has no deductibles and no cost sharing for routine care. Although, of course, the future of the subsidies that facilitate this program are in question. But as another example from the public sector in Minnesota, the state employee health plan has members select primary care clinics that manage their care, and these primary care clinics are placed into cost-sharing tiers based on their total medical expenses, such that member cost-sharing responsibilities vary by the tier of their clinic, and this can be known to patients in advance. We were also interested on the private sector side to learn about Surest, which is an insurance offering for employers from United, which uses a fully co-payment-based model with no deductibles, no co-insurance, and no cost sharing for common ancillary services at primary care visits. Instead, co-pays are fixed for every episode of care, regardless of the services that happen at that episode, and are higher for higher priced providers and care settings. And that these copay amounts are available to patients in advance of making an appointment via an app, so patients can actually do that shopping. The next slide, we get into some of the modeling that I mentioned to explore the feasibility of changing how we approach deductibles in Massachusetts. And we're not, necessarily recommending doing specifically either of these things, but we did this modeling sort of as proof of concept. In our first example, deductible spending is capped at $500 a person, which on its own, as you'd expect, increases premiums by about 6%. But that increase can be offset by limiting prices, by shifting deductible spending to copays, as inspired by the Surest example. In our second example, deductible spending is eliminated only for primary care E&M visits, which on its own would increase premiums by 0.3%. But again, that increase could be offset by redistributing cost sharing or by limiting prices. So just to wrap up, we wanted to offer some policy options to improve cost sharing in Massachusetts. That the Commonwealth could foster the offering of health insurance products with more consumer-friendly, predictable benefit design, including favoring copay-based designs over deductible-based designs that redistribute cost sharing rather than raising premiums. And that improving affordability writ large may also require policy change related to elements such as minimum levels of hospital charity care, because even with more predictable benefit design, patients may still incur high hospital bills. And of course, reducing growing prices needs to remain a policy priority as part of all of this work, because growing cost sharing and rising deductible amounts ultimately reflect the rising underlying costs of care. Thank you.
Thank you, Sasha. And we'll just advance to some discussion questions and really just want to open us up to additional thoughts specifically around cost sharing as it relates to primary care, and whether their task force has ideas around how might redesign cost sharing facilitate access to primary care, and other ideas that you'd like the Health Policy Commission, perhaps with the Commissioner of Insurance, to continue to explore and to think about. We'd be happy to do additional research and come back to this group. And then additional question is, what other elements of plan design do you think are worthy of continued investigation by this work group as we tackle this fifth deliverable, assessing the impact of health plan design on health equity? Here we're focusing on cost sharing today. So two big questions. We've got about 12 minutes. Laura, I'll start with
Thank you, David. Thank you very much, as I'm having a slight emergency here. I appreciate you, the work you're doing here. I do think this can't be done in a vacuum. I don't think the business community is represented here today. They need to be a part of this conversation. Businesses are moving to high deductible health plans because of our failure really to address the affordability issues in Massachusetts. So I do think your point, working with the Commissioner of Insurance, working with actuaries to understand how these changes would affect the business community by way of increased premiums if we do anything on the deductibles. I think one of the slides suggested that a change would add 6% to premium. That's on top of trend, which can be running at 14%. So that creates a problem for the commissioner as he's trying to approve affordable rates. So I think, again, this can't be done in a vacuum. It has to be a very thoughtful conversation, and the business community needs to be a part of this. As somebody who runs a small business, I'll tell you, and I testified to this last year, I'm right in the process right now dealing with my budget, looking at our benefits and whether I'm going to be able to give raises, contribute to 401ks, or making adjustments to health insurance. I think a lot of employers make adjustments to health insurance as a way to be able to give raises to their employees. We have really hard choices to make. So those are my comments as we think about this. And, I do think that right now we're in an affordability crisis in our state. We have plans as well, and some in the provider community who are not doing well. So I think we need to be very, very thoughtful in how we approach this. I'm not sure that we can make drastic changes unless we truly understand their impact. So thank you for allowing me to speak.
Of course, Laura. Thank you. And I'm just going to go in the order here. Dr. Altman.
Hi. So in 2021, the National Academies of Sciences, Engineering, and Medicine produced a report on primary care, and they said that primary care is the only aspect of healthcare that both improves health and decreases health disparities. And primary care does both of those things, all while lowering the total cost of care. I call this the triple superpower of primary care: cost, health, and equity. And yet, we place a barrier between our patients and primary care. In the dashboard, there is a discussion of usual source of care, and we lament these low numbers of patients who actually access primary care and have real relationships with a primary care clinician and have a usual source of care. But we systematically encourage them or discourage them from having a usual source of care by these huge copays and deductibles. The common story here, I'm at my office right now where I'm about to start seeing some patients in a few minutes. And the common story we see here is when people come for a physical and they show us that list that Barbara appropriately encouraged her son to prepare for their physical. And they also tell us, this is the list of questions I had, but I'm choosing not to ask because I can't afford the cost sharing. So just go ahead and do my physical. I won't ask the questions I have about my health, which is heartbreaking. Sometimes they share that, sometimes they don't. When they share it, we end up just not billing them for it, which is technically fraud. But we do it anyways because we just want to help them. But this is the system that we're dealing with. So you're asking for proposals of how we could do this. It's very simple. Eliminate cost sharing from primary care. Establish a primary care payment model that has no copays and no deductibles with primary care. I will say our 3 primary care bills that have been filed this session, one of them calls for the complete elimination and the other 2 call for a dramatic decrease of cost sharing in primary care.
Thank you. Suzanne? You're on mute. Sorry, we can't hear you.
Sorry, thought I clicked unmute. Thank you. I just want to thank you, David. Commend all the work that you've done at the Health Policy Commission in thinking about this. It's obviously very important to us. Just piggybacking on what Dr. Altman said around cost sharing, as we know it's a barrier. At the very least, we would love to look at reducing cost sharing and taking out the deductible structure if possible. If not eliminating it. However, I do also agree that we need to look at kind of the impacts on other services and on premiums. So I understand kind of the impact it can have there. And also agree that we need to look at pairing this, as I think we all agree, pairing any cost sharing changes also with looking at more systemic reforms to bring down costs. I know we have still a lot to do on prescription drugs, for instance. I know that's a big area of interest for us and for that we might share mutually. And so there's other things we can do. We know they may not happen necessarily on the same time frame, but that we need to pair both the system and consumer costs. I do want to make two other quick points. One of the models that Sasha showed around Minnesota and the tiered networks, I will just say, I'm not this is not generally our view, but I think it would be personally, I think tiered networks are very difficult for patients, and especially when you're thinking about the capacity issue we have in people getting into primary care. It does not seem like from a consumer endpoint that would be very helpful. And shopping around for services generally is very difficult. I mean, I can tell you, I kind of just go, my PCP is like, go here, or like, get this lab test, I'm sending you down the hall. That's where you go, right? Like, you don't have time or bandwidth most of the time to shop for these services. So overall, I just want to make that point. And then last, I want to say on the preventive services piece, I'm glad you mentioned that. There's still work to be done there. We're very fortunate to be working with the Division of Insurance, Commissioner Caljo, and KPMG at looking at women's preventive services in particular, and seeing what the impact is there. So we're going to be doing focus groups and a lot of other work, and we're happy to bring any findings we have back to this group that may be helpful. Thanks.
Thank you. That's excellent, and agree with the comments around affordability and prescription drugs in particular. Something we're thinking a lot about here at the HPC, but I appreciate all those comments, Commissioner.
Briefly, and thanks, Suzanne, for mentioning our work together on women's healthcare. We're really excited about that work. I want to go back a couple of slides to the comment about the recommendation about the development of product designs that incent better cost share approaches to primary care visits and give us a check mark plus, as we used to say back in elementary school. I'm proud to report that we can show that we have actually achieved success on that point. The Division of Insurance just approved this summer the introduction of that Surest product into the market. And so it will now, and that's public information that's already been made available to all the plans. That product will now hit the market beginning on 1/1 of 2026. And I think many of the health plans, if not all, will be filing similar efforts. The secret to success for that product is that it's motivated by incenting care at low price providers that happen to be primary care providers. And so I think it's a great example of where value-based design and contracting go hand in hand. And I think I just wanted to mention that if we're moving the market, that type of innovation is really important for us to embrace. So checkmark plus on that particular recommendation.
Yeah, that's great, Commissioner. Thank you for sharing that with us and for your leadership on that. And as you said, innovation in this space is something that we want to encourage, and we'll be tracking this closely to see what the results are. Mark, and then Senator, I'm going to give you the final word on the meeting today.
Yeah, thank you. Really interesting discussion. Just a thought. I mean, just want to hit that point one more time about I know everybody knows that the balloon phenomenon here. If we reduce out of pocket and we do nothing to change the cost trends, then premiums will go up or coinsurance will go up, and we'll be talking about coinsurance in a year. And that could be the next thing, right? That's also unpredictable, and in fact, as a lot of aspects that are even less desirable than deductibles because it's not capped until you hit your out of pocket maximum. So with that in mind, though, I mean, there's a little bit of a reductionist view going on here. If premiums do go up and that comes at the expense of wages, we don't actually know the health effects of doing that for a population. That's a dicey proposition. The other thing I just want to point out here, when we start lumping labs and ancillaries into primary care and entertaining the idea of also exempting those from cost share, I think we could get into some territory where we're kind of going against the spirit of all of this. $0 out of pocket for preventive care, which is value-based insurance design. We have this idea that it's true. I mean, the Rand health insurance experiment and health studies for 50 years have all shown that when you have higher out-of-pocket costs, people clamp down on all kinds of care, whether it's useful or not. If we do the opposite, we could probably reasonably expect, if we're not precise about how we do this, an uptick in the consumption of unnecessary and actually quite harmful care, including unnecessary laboratory tests.
Thank you, Dr. Freeberg. Senator, your reflections on this conversation.
So I just to follow up on Mark, we should put it up on every banner we have, is that the goal of this is not to increase the costs in the system, it's to shift the costs in the system. And we'll keep saying that, and people will keep picking up other things, but that's the shift, okay? The other thing is as long as you continue to pay people for individual services, you will get more labs and you will get more, you know, a cost for ancillary care. And if I mean, I guess we could learn this again, but if we need to walk and chew gum at the same time, we need to be able to say, we're going to allow individual practices to have the infrastructure they need to provide the care. And then we're going to give them a global payment, because if we just keep paying for the services, then they're real human beings. They're going to just keep, giving the care, and they're going to be worried about whether they don't give the care or not. So I think we know a lot, and we should acknowledge that we know a lot. And maybe it's things that people aren't going to like, but it doesn't change whether it's good or not for the system. So I just, just from listening to this and from what people are saying, is that I think we kind of know a bunch of stuff, and we should acknowledge that. And we can't keep adding money to the system. So let's have that little banner every time we get together that says, shift the costs, don't increase the costs. And that means you don't have to raise your premiums by 6% if you're doing something that is really going to make people healthier and going to make them stay out of the hospital, and they aren't going to need the specialists. And if we believe that, then that's what our system should reflect. So those are my thoughts.
Thank you, Senator, and thank you for linking some of this conversation to the other conversations we've been having in this task force around changing the way that we pay for primary care, and linking that to this conversation as well. I think we could do a little banner at the bottom, just a little footnote just on each one of the slides. I think we all agree. So thank you, task force members. As I said, I do think this will probably be our last work group meeting of this calendar year, but we want to continue meeting. We still have work to do on these deliverables, and this deliverable in particular, deliverable number 5. I would love, we didn't really get a chance to talk about, are there other elements of plan design that you think are important for us to reflect on? But I would invite you to reach out to Kelsey if you have thoughts on that. If there are topics that you would want to talk about at a future meeting, we'll be back out to do some scheduling for the new calendar year. But we do have an upcoming meeting of the full task force on Wednesday, December 3rd, already scheduled. We are hoping to potentially do that in person here at the HPC office. If you haven't already responded to Kelsey's prompt about whether you can come in person, please do so. We're going to tally all the responses and make a final decision. But thank you so much for all of your service so far this year. We're going to keep at this, and have a great Thanksgiving.